let us introduce our latest speaker, our good friend, Dr. Wei Hwa. He will let us know about the stent, bare metal stent in the treatment of central vein stenosis.
Okay, thank you, Dr. Liu, for the kind introduction. I'm the last speaker of this final session, so please stay with me for the final minutes, and we can, we can turn off our app after this talk. So we know that the bare metal stent, a lot of evidence show that it's not really the best option for central vein stenosis. So today I'm going to share some of my view for our algorithm using bare metal stent to treat this central vein stenosis. I have nothing to disclose. So we treat a patient with symptoms. So these are the symptoms that we usually met with patients suffer from central vein stenosis that we needed to treat them. So we have heard from the previous speaker about some problems that cause central vein stenosis, like central vein line, like extrinsic compression of the adjacent structure, coagulopathy, pacemaker lead. And for me, I think the problem is that a lot of dynamic compression by LT arch and bony structure, which I learned from my IVUS experience. So the main algorithm to treat it is to do the prevention. So never try to place catheter ipsilateral to the side you created access, and use less central vein catheter from the subclavian vein, and also avoid prolonged placement of the central vein catheter, and also treat the patient if the patient is symptomatic. Don't treat any lesion that's not symptomatic. And I think our goal to try to preserve try to treat the central veins, we try to preserve the access. So it's not that we like to put stent, it's just that we try to preserve the access, because if you don't do that, a lot of symptomatic patients, they might need to give up the access. So we learn from a lot of evidence that cover stent do much better than the bare metal stent. And the bare metal stent actually has the same effect with the plain balloon angioplasty. So this is data that that the PTA doesn't do well. So 30% patency at 12 months only. So currently the recommendation is that we treat the patient with symptom, and also the patient should have residual stenosis after PTA more than 30%, and also the lesion recur within 3 months of angioplasty. So the patient need to be the recurrent patient, and there is a residual stenosis after you do the plain balloon angioplasty. But the problem is that the bare metal stent don't have a very good result in the long run compared to PTA. And we start to use stent graft to treat this part of the patient, because the stent graft has a lot of benefits, including the better radial force, and including there is a barrier for the ingrowth of the intima that we think before. And if we do have any other stent that share the same characteristic as the stent graft, can we use that? Can we use a venous stent, which has a good radial force, even much better radial force than the stent graft? So this is data that we learned from the literature before, that actually the stent graft at this position, 1 year primary patency is 67%, and the assist primary patency is 80%. Currently that we use IVUS in most of the case that we do with the central vein intervention. And before we use stent graft, especially sometimes we needed this endurance limit is actually apart from the EVAR, which we use the limb as the stent we pick, because the size is bigger, and we believe that the radial force is better. And also we can modify the stent on the table, because the length sometimes varies among the lesions. So you can't use, sometimes you need to modify the stent. You don't want to cover too much. And this is the size that we measure from the IVUS. That actually for the subclavian vein from the IVUS, the normal size is range from 14 to 16. And the innominate vein is 16 to 22, and right innominate 12 to 16. So this is the area that we estimate for a normal patient. So this is the study we done previously. After we do 82 cases using the stent, that we try to look at the data, and then we found that most of the case we use is stent graft Viabond, and some we use the AAA limb for this cohort patient. The mean follow-up time is 600 days, and the mean age is 69 years old. So most of the place that we need to put the central vein stent is the subclavian vein, is 48%. And the innominate vein, actually, there's 43% of patients needed to put the stent. And we seldom put the stent in the SVC. And for the ISR cases, actually, there's 32% of the cases are ISR cases. So this is the initial data that I show you that actually the self-expandable stent graft actually has a quite good access circuit primary patency. And for the target lesion primary patency, as you can see here, at 1 year, it's more than 80%. So which is better than the data that I presented to you before. It's 60% from other literature. So if you can use the bigger size of this stent graft, then you might get a better result. And the patency can last until 2 years with 80% of target lesion primary patency. And also, if we use IVUS in these kind of cases, we found that the diameter of the stent that we use will be bigger compared to the case that we didn't use IVUS. So we believe that IVUS had added patency to this procedure. So this is the data that we just look at the self-expandable stent graft. As you can see here, the target lesion primary patency is 84% at 1 year, 80% at 2 years. And if we use IVUS, we have even better patency, as you can see here. So it's for us that we believe that because we can more accurately measure the size of the stent, then we can have a much better result. So if we already have a much better stent graft result over here compared to the previous literature, why should we choose to other stent? Because stent graft still got a lot of problem. One problem is that when you cover the stenotic part, sometimes you have to cover some outflow, some inflow. So sometimes we need to sacrifice the interjugular vein, and not all the patient is asymptomatic if you cover those inflow. And also some stenotic lesion is very long. So we have some problem with the lesion, which from innominate vein to subclavian vein, sometimes you need very long stent. So is it possible that we use just bare stent and don't have to cover everything? And also one big problem with the stent graft is that we still have some problem over the costal clavicular junction. We still have compressed Viabond or compressed fluency over the area, because that area sometimes will collapse the stent graft even if you put 2 stent graft there. So this is another problem. So a lot of surgeons, they think that the surgery is more appropriate for this part of the central vein. And also the profile of the stent graft is bigger. So it's not really a big problem to us because we are vascular surgeon, but still I think if we can have a smaller profile of stent, it will be much better. So this is the stent that we usually use. Actually, the first one is the wall stent. So they have a different configuration. So the last one is actually the Venovo, the second generation venous stent. It's a laser cutting stent. And this is the picture that we get. If you put a wall stent there, as you can see here, that it's just compressed and it's very difficult to do other intervention. And we can also see another picture here is using the balloon expandable stent. And you can see here, the stent looks open, but actually the stent is fully compressed. So actually the stent is already occluded. So this is other problem with the first generation venous stent or other bare stent. So how about this venous stent? So we use this second generation venous stent over the iliac vein initially, in my experience. I think that a lot of benefit for this stent because it has a very good flexibility, high radial force, and high compression resistant force. As you can see the data here, as you can see, like compare this stent to other stent like Zuvavena. Actually, they have the wall stent have a much better radial resistive force. As you can see, what I highlight here, and they have a similar characteristic with the sinus obliquus. or other second generation stent. So this is one of the benefits of using this stent. And this is also the study from, you can see here the Venovo have a much better crowd resistant force compared to the Optimed sinus venous. Even it's much better compared to the Cook Zero Vena. And also the stent flexibility is very important here. And it comes with larger size available now in Taiwan, it's a 20, and the longest length available is 10 centimeters. But actually, they have a longer one, but it's not available now in Taiwan. But I hope that in the future it's available. So we know that from the calculation that 19% increase in the radius will double the volume flow rate. So the size is very important when you do this central vein stenting. So this is the case that I show you. First, there's a case that before we used the balloon assembled stent here for the innominal vein stenosis occlusion, and then we found that actually the patient present with the compress of the stent H by the costal clavicle junction. So in this case, we try to use the second generation Venovo to salvage. As you can see here, after we do this Venovo stenting, we follow the patient, and it seems the Venovo do quite well. And even the distal part of the stent become a flare configuration, which is really quite crush resistance. So, sorry. Okay, sorry. So this is 1 year. After we put that Venovo stent, you can see here is the configuration is still doing well. The patient is asymptomatic, is doing well. So the case 2 here, initially the patient present with venous hypertension. We did not treat the central vein. We just treat the outflow of the cephalic arch. And then 6 months later, the patient actually developed venous hypertension, become the swelling of the leg upper extremity. And we used the IVUS, and we found that actually the venal gland shows compression of the innominate vein, but actually it's very, very much compression. It's more than 80% of stenosis. So we need to treat that part. So this is the calculation that we measured all the way the innominate vein, and that we figure out optimal size for this part. We use a 16 times 60 millimeters Venovo for here. And then 11 months later, I don't know whether you can see the slide properly, but I actually can see the configuration of the stent is very good. It's not compressed, it's very good. So this is another case that we have a pacemaker incidentally placed on its lateral part, and the patient suffer from swelling because of the axis and the same site. And then you see we use a Venovo for this area. And then we found that 6 months later, the patient is doing well, and the configuration is still good. And we do notice some very special thing about using the Venovo, like in this case. You can see at the 3 months, I'm a bit worried when I put stent here, because looking at the stroke, I'm afraid the stroke might get compressed or might get fractured. But actually, I think it's because of the motion of the patient. So if you see at the 6 months, actually the configuration of the stent stroke seems okay, and 9 months is still doing well. So I think the Venovo is really cross resistance when you use at this costal clavicle junction. So I think it's very different from the other bare metal stent that we used before, that was used in the artery. So we only did 14 lesions, 12 patients until now. So we use IVUS guide for all the procedures, and male and female is 3 to 9, and the mean age is 65 years old. And most of the access is on the left side, and we have a more arm AV graft compared to AV fistula in this patient. And then the lesion mostly is a stenotic lesion, and the de novo lesion, most of the case is de novo lesion. So this is the position of the stent that we put. So we have subclavian vein, right subclavian vein, and also innominate vein. Innominate vein is not so compression, so I think the most difficult part may be the subclavian vein. If the stent can survive the subclavian vein, then I think it's appropriate as used as a stent for the central vein stent. So the mean follow-up is until now is 213 days, and then we follow the patient with X-ray to check the configuration of the stent. And also we use the 6-month and 12-month angiogram to confirm. So up to now, our mean follow-up is 200 days, and then the target lesion primary patency at 6 months is 100% patent, and the access circuit primary patency at 6 months is 78.6%. This is the data, the survival curve that I show as we mentioned before. And I think the Venovo currently at 6 months, the data is quite encouraging. So finally, conclusion of my talk, the summary, I think we already have a lot of experience with stent graft. Actually, the stent graft can be done well if you use IVUS guide. It will have a quite promising target lesion primary patency. So, but for the second generation venous stent, I think it has can overcome some of the problem with the stent graft. And initially, our target lesion primary patency at 6 months is 100%, and the access circuit primary patency is 78%. I think the target lesion primary patency matters with the sizing and also adequate seating. And I think the Achilles tendon for central vein stenting is always the coastal capillary junction. And in this part, I think from our very limited, very small group of this using the Venovo stent population, we find that actually it's doing well at this area compared to the other stent in this coastal capillary junction. So I think we have to follow up the patient for long enough and then to watch whether this will prevail after 1 or 2 years follow-up. Okay, thank you for your attention.